Let's start with my major conflict of interest. I'm a fan of lung ultrasound, and I'm personally convinced that this is the best tool at the bedside to have a quick and informative look at the lungs of mechanically ventilated patients. Oh, sorry. For instance, with a progressive decrease of air content in the lung tissue, the lung ultrasound patterns changes. So, an ultrasound-based lung ultrasound score has been recently proposed, ranging from 0 to 3, where 0 is the normal lung, the normally aerated lung, with horizontal reverberation artifacts called A-line. So this is the A pattern. And 3 is complete loss of aeration, when you see a tissue-like pattern. Intermediate degrees of aeration, score 1 and score 2, corresponding to moderate and severe loss of aeration, are characterized by vertical hyperechoic artifacts called B-lines. In the original score, these B-lines are well separated in score 1 and coalescent in score 2. I like automation as well, because automation makes our life easier, and automatic grayscale analysis to detect and count B-lines was very recently validated, and actually it is already implemented in echo machines. We compared this lung ultrasound scoring system with the gold standard, that is CT scan, quantitative CT scan. And you can see that lung regions with different lung ultrasound score have also different lung tissue density. So for each step increase of the lung ultrasound score, there is a significant increase of density. Anyway, there is some overlap, and this is particularly true for score 2, severe loss of aeration. So in order to improve the capability of the ultrasound-based scoring system in distinguishing moderate from severe loss of aeration, we suggest to use a modified lung ultrasound score based on the percentage of pleura that is involved by artifacts. Less than 50% is score 1, more than 50% is score 2, that means severe loss of aeration. And this modified lung ultrasound score was recently validated against transpulmonary thermodilution. You can see that compared to other ultrasound scoring systems based on coalescence of B-lines or number of B-lines, it was better correlated with extravascular lung water, that is lung edema. If you grade 6 regions per pneumothorax in your patient, so in total 12 regions, you can compute the global lung ultrasound score. And again, this is very well correlated with the gold standard, so with the average lung tissue density as assessed by CT scan. Many practical use for this monitoring tool. For instance, in our unit, we perform a daily ultrasound assessment in ARDS patients, especially in those patients under VV ECMO. And this is from our initial experience. You see how the patient who died on ECMO had a completely different trajectory compared to those patients we were able to win from the extracorporeal support. And this is a very prolonged monitoring along almost 3 months of awake ECMO. We perform 5 different CT assessment, CT scan in this patient, and we use lung ultrasound to fill the gap between 2 CT scans. Lung imaging may also help management of patient mechanically ventilated. For instance, we know that patients with the focal loss of lung aeration, like the one on the left of the slide, are poor PEEP responder, whereas patients with a more diffuse disease, like the one on the right, may positively respond to PEEP with some lung recruitment. So lung morphology can be used to personalize mechanical ventilation setting in ARDS patients. High PEEP in diffuse disease and low PEEP plus prone positioning in focal disease. In this recent randomized controlled trial, this strategy was compared with a conventional one based on PEEP FiO2 table. Unfortunately, I would say disappointingly, this trial is negative. No difference in outcome was observed between the personalized and the control group. However, lung morphology in this trial was assessed with standard chest X-ray in the majority of the patients that were misclassified in more than 20% of the cases. Let's say that this was not completely unexpected because we know that standard chest X-ray has a very poor diagnostic accuracy in ARDS patients, not that different compared to chest auscultation. And once misclassified patients were removed from the analysis, a lower mortality was observed in the personalized group. Moreover, and even more interesting to me, in the personalized group, misclassified patients had a very, very poor outcome. That means that if we set high PEEP in focal disease and low PEEP in diffuse disease, both increase mortality in our patients. So probably we can conclude that personalized PEEP setting according to lung morphology is a very good idea. There is a strong rationale behind it, but certainly we need better tools to assess lung morphology and predict the recruitability in our patients. And for this, the gold standard is CT scan, is quantitative CT scan. But unfortunately, CT is not a bedside tool. It's expensive, it's time-consuming, of course, is an irradiating technique. So I think that CT cannot be reasonably adopted in everyday clinical practice to set PEEP in our patients. At the bedside, PEEP-induced lung recruitment can be measured, can be assessed by performing several inspiratory pressure volume curves at different PEEP level, or as an alternative by measuring the end expiratory lung volume with the wash-in, wash-out technique. The two methods provide consistent results, but if you can measure at the bedside end expiratory lung volume, you don't need a PEEP release maneuver to assess recruitment. And this is a clear advantage because it's not always safe and feasible in ARDS patients to remove PEEP. On the other hand, if your mechanical ventilator can perform both inspiratory and expiratory pressure volume curve, you can profit from the fact that the hysteresis area, so the area between the two curves, is directly correlated with lung recruitment. That means the larger this picture on the left, the more recruitable the lung is in your patient. And finally, lung imaging. I think that lung ultrasound, so checking the anterior regions of our patient with a probe, is a very easy, fast, and reliable way to assess lung morphology and predict recruitability in our patient because lung ultrasound has a clearly better diagnostic performance compared to standard chest X-ray, at least in ICU patient. Once PEEP is set, yes, you can compute a re-aeration score to get an idea of the amount of volume gain associated with your new PEEP level. But what I really like of lung ultrasound is that you can see at the bedside lung tissue recruitment and check whether your maneuver was effective in real time. Interestingly, patients with almost normal aeration in the anterior lung regions are poor PEEP responder, but positively respond to prone position in most cases. And in this patient with focal disease, focal lung morphology, experience more re-aeration of posterior dependent part of the lung when in prone position compared to patients with a more diffuse disease. And the amount of this reopening in the posterior lung regions is associated, after the first prone positioning, is associated with mid-term outcome, defined as a PF ratio higher than 300 after 7 days of daily prone positioning. Okay, because lung ultrasound is correlated with lung edema, we can use ultrasound to help us in the management of fluid loading in ARDS septic patients. In fact, ultrasound is more sensitive than oxygenation in early detection of lung worsening related to fluid loading. So we can use ultrasound to know when to stop fluid loading in this setting. Finally, weaning from mechanical ventilation. If you perform a lung ultrasound assessment after a successful weaning trial in your patient, you'll see that patients that are going to fail extubation have a higher lung ultrasound score. There is a gray zone, but a value higher than 17 is highly predictive of extubation failure, and a value lower than 13 is highly predictive of weaning success. And very similarly, if we check lung ultrasound at ICU admission after major abdominal surgery, we can predict the need of postoperative ventilatory support or respiratory support. And to conclude, this is my personal list of reasons why to assess and to perform lung ultrasound in critically ill patients, you can also find in this recent review paper. Thank you for your attention.